session is called Diagnosing Hypoxemia and Pulse Oximetry, and we are pleased to have a number of panelists from around the globe. Our presenters are Drs. Pepito
Nous avons un
Natambwe.
nombre de participants à travers le monde.
Sorry, Soham, if we could mute the interpreters off the main line. So our presenters are Dr. Pepito Natambwe from Livingstone Central Hospital in Zambia and Dr. Pauline Benguti from the University of Rwanda. And we are also pleased to have a number of co-panelists, including Dr. Farai Matsimbamuto from the University of Zimbabwe, Dr. Alexi Milan from the University of Botswana, Dr. Christina Menner from Lifebox, Dr. Julia Weinkoff from the University of Minnesota, and of course, Dr. Anna Maria Crawford from Stanford University. Before we start, we do have a couple of housekeeping items to go over. Oops. Sorry. Just to begin, Project ECHO, as a reminder, is based on a foundation of love and respect. So please respond kindly rather than react if you disagree with something. It is everybody's responsibility to keep ECHO a safe space. We will be using the chat function for question and answer. The chat function box is at the bottom of your screen, so please send all of your questions through the chat box and feel free to introduce yourself. Interpretation is also being made available today. I'll explain that on the next slide. Please turn on your video, position your webcam effectively to show your face if alone or to capture the whole group. To obtain a certificate of attendance, you will need to fill out a short survey. We will provide a link for this in the chat to access near the end of the session. If you are having IT issues, please send a message through the chat to Echo IT, or you can email our colleague Soham at the email indicated there. And this session is being recorded and your attendance is consent to be recorded, so thank you. And finally, please be mindful of infection prevention and control. Try to limit the numbers of people joining this learning session from one gathering place and practice physical distancing. So for interpretation, the button to choose interpretation can be found at the bottom of your screen. We recommend choosing to mute the English part of the session to hear the interpretation most clearly. And so if you would like interpretation in French, please select French. If you would like interpretation in Spanish, please select Spanish, Portuguese, Portuguese, and Swahili, Swahili. The instruction here says please choose German. Disregard that. We are able to provide a Swahili button today. And then finally, we do have a 30-second poll that we would like you guys to complete before we hand over the session to the presenters. This is so that we can understand what language lines are being used today. So if you could please spend 15 to 30 seconds just completing that, that would be fantastic. Soham, if you could launch the poll there for us. And if you are a panelist, interpreter, or co-host, please do not answer this poll. So we'll just give you guys another 30 seconds there.
Est-ce que vous me voyez? Est-ce que ça marche maintenant?
So I think the French interpreter is on the main line again.
Yes. Hi, Sylvia. Sure. Can you try like using another device, because I think there's something wrong with the device you're using right now. It's not allowing us to like give you the booth access. So try joining from a different device. Once you join, I'll give you access to the booth, and that should work for you. Thank you.
Okay. Thank you everyone for completing the poll. I'll now hand it over to our presenters, Dr. Pepito and Dr. Pauline Benguti, to start the session.
I'll actually, Alana, share some of the materials for the Learning Resource Center. So first, I would like to say welcome to all of our participants. We have over 700 users now on the Learning Resource Center. So this is a blended learning experience where we couple these teleeducation sessions with asynchronous modules on what we call the Learning Resource Center that participants can access at any time. So I want to briefly share my screen. Right, is that visible, Alana?
Yes, thank you.
Okay. So just probably 2 minutes for me to go through some housekeeping items about the Learning Resource Center. You all should have received a link in the sign-up materials. The first thing I want to share with you is our disclaimer video. It takes about 1 minute. Are intended to promote the exchange of knowledge and experiences of healthcare providers. Learning modules are in no way intended to substitute the clinical judgment and independent decision-making of qualified healthcare professionals. Viewers of this material are fully responsible for their own clinical decision-making. Creators of these materials are in no way liable for any claim, loss, or damage resulting from information used in this Learning Resource Center or during discussions. Creators and administrators of the Learning Resource Center make every attempt to provide up-to-date and accurate information. However, information changes rapidly. Creators and authors cannot claim responsibility for inaccurate information. Individual healthcare providers are responsible for adapting information to fit availability of resources and standards of care in their own institutions. Okay, so that just explains that we're going to give a lot of resources and share a lot of discussion, but ultimately you're responsible for your own clinical decision making. On the Learning Resource Center, we want you to realize that because there are close to 700 users on the Learning Resource Center, that in addition to our WhatsApp group, that's an excellent way for you to connect with your global community. And so on the Learning Resource Center, this video will show you how to do so. One of the most powerful components of the LRC is access to a global network of providers in varying practice settings. Engaging with others is power for innovation and a great resource for novel solutions to clinical problems, especially when resources are limited. We would like to show you how to connect with this valuable community. Signing into the LRC is the first step. You can see the sign in button in the upper right-hand corner of the home screen. On the sign in page, you can create a new account for free. We pledge that all our courses are open access and free from advertisements. If you have already created an account, then you can sign into your account by entering your email address and password. If you forget your password, you can also reset it on this page. The LRC also allows you to sign in with any of the social media accounts. Once logged into your account on the LRC, you can access the community page in one of two ways, from the landing page or from within a course. This slide shows you where to click on the landing page to access the community page. This slide and the next show you where to click to access the community page once you are already inside a course page. First, you can click the LRC icon at the top left-hand side of the page. Then, you can see the community button here, indicated by the red arrow. Clicking this button then takes you to the community page. Once on the community page, you can access the discussion forum. You can type a message to all learners, you can create discussion groups, and you can type messages just to learners in a specific course. Please note also the mail icon in the upper right-hand corner. You can click this envelope to check any messages you receive. Another way to start and participate in a discussion is from within a course and within a specific learning element. Here you can see we are within the course called The Fundamentals of Critical Care. We are viewing the second learning module called Minimum Standards of Intensive Care Units, and viewing a learning element, which is a video called Minimum Standards of an ICU. From here, you can click on the tab that says Discuss. Once on the Discussion tab, you can leave a question or comment about the learning element, in this case, the video. We hope these tips help you engage with your community so we can all make improvements in patients' lives. Happy learning. Okay, next we want to share with you the partners that brought these sessions together so that we can be transparent in the information that we are providing. So this page shows you the disclosures and conflicts of interest. As you know, Project ECHO is a collaborating sponsor for these sessions, as is Assist International and then Stanford Global Anesthesia. Okay, and with that, I will turn it over to Drs. Papicho and Paulin.
Thank you very much, Anna. Good morning or good afternoon, depending on where you are watching or listening to us. And nice to have you on today's discussion, hopefully to have a very interactive discussion. And we call on anyone to participate actively, either by asking questions or by writing down comments on the chat box. Today's discussion will be about diagnosing hypoxemia and pulse oximetry. For this, we use a case-based discussion, and in between there will be some questions that will be asked, and then we'll be required to be answering the question by writing in the chat box. Thank you. So the case discussion will be a 57-year-old man who presents with chills, weakness, and dry cough. So when he comes, you'll find us in the casualty or in the department where we'll be waiting from, and then it will be our responsibilities to diagnose hypoxemia with our pulse oximetry. For today's learning or today's discussion, we have a number of objectives that we will have to achieve by the end of the discussion. The first one will be understand how to use a pulse oximetry during the COVID-19 pandemic. As we know, this time, the pulse oximetry have become so much in use, but what matters is to know how to use them and correctly use them, and mostly how to keep them safe. So today we'll discuss and discover how to take care of the pulse oximeter. The next point is understand and recognize a pulse oximeter latency. Here we'll discuss on how pulse oximeter acts, how long does it take approximately for it to give you the readings that you expect to get from the patient. And we tell you what are the factors that interfere with these readings. The third point of our objectives will be to select and rank oxygen delivery devices by FiO2 being delivered. A number of delivery devices that we'll go through during our discussion. There will be a question that comes up, and then you'll be asked to do a small exercise. And then we'll discuss with some more comments from other panelists who are already on board. The next point is the use of Lifebox triage tool to select the most appropriate oxygen delivery device available. There's an interesting tool that was developed by Lifebox, easy to interpret and to understand. We'll go through it, and then comments will be made appropriately. The next point will be the use of the same tool in the need of patient, for the patient who are in need of oxygen. So we show you how to follow up, how to do the best choice for the patient. The next point of the objective is to assess your facility non-invasive oxygen delivery device. We have so much responsibilities in our institution, so each one will be taught or will discuss how you can do assessments of the non-invasive oxygen delivery in your facility so that you see what is missing, what you have, where it is, and when to use them. The next point is to assess the type of oxygen supply at your facility. This is another important point. We have so many differences in terms of oxygen supply, depending on our location, depending on the fundings that the institution have, and so many factors come on board for you to have a different type of oxygen supply. The next point is to interpret data obtained using pulse oximetry and understanding the limitation. After this, we'll come to list the conditions that interfere with accurate pulse oximeter readings. And lastly, not least, how to take care of our pulse oximeter, cleaning and maintenance of the device so that it stays longer and continue giving a good result or a better job. It will be interesting if when we go on the LRC, we get to download these practice improvement objectives so that we get to utilize them when we are doing our own readings. For our case discussion, so that is the checklist that we can download when we go on the LRC. Thank you. So our discussion of today, as we said on introduction, it's a 57-year-old male patient who presents with a 4-day history of chills, weakness, and cough. His wife, who's a nurse, tested positive for SARS-CoV-2 3 days ago. His SpO2 read 89% at home, so his wife sent him to the emergency department. At the hospital, the patient was screened for COVID-19 risk factors, isolated from other patients, and is wearing a face covering. You and the nursing students are wearing PPE for contact, droplets, and airborne precautions. So the patient admit is short of breath with moving and eating, but denies fever, shortness of breath at rest, loss of taste or smell. He states he has been less active and staying in bed. The vital signs readings, the heart rate is 95 beats per minute, the blood pressure 95/52 millimeters of mercury, respiratory rate is 24 beats per minute, and SpO2 of 89%. The temperature is 36.5 degrees Celsius. So you recognize right away that the patient is hypoxic and started him on oxygen by nasal cannula at 5 liters per minute as flow. His SpO2 initially improved to 97. So that was our case discussion. Throughout, to do reference to this same case, and then later on we'll develop the next steps of the same patient. As at for now, we would like to know, in your institution, how is pulse oximetry used in the COVID-19 pandemic? If you happen to get a patient like this one or something close to this, how will you use the pulse oximetry? To answer this question, you can drop up your answer in the chat box. We can allow like 1 minute, and then the panelists will go through the answers, and then we make a comment, and there will be a discussion soon after. So we can click on the question. And then there will be a video that we'll watch. This video is about use of pulse oximetry. It shows you so much about a pulse oximeter.
Video shows the oximeter in the context of the COVID-19 pandemic. Severe COVID-19 primarily affects the lungs. Measuring oxygen saturation is essential for deciding when to use precious oxygen resources during the pandemic. A pulse oximeter is used to measure oxygen saturation and can help identify severely ill patients who should be hospitalized and receive oxygen therapy. Please note, available oxygen, flow rates, and administration practices will vary according to local protocols and resources. Make sure you know what kind of oxygen therapy is available in your institution, how it can be delivered, and what local guidelines are in place. Do you need to measure your patient's oxygen saturation? You will need to decide whether your patient should have their oxygen saturation measured. To decide, you will need to ask 5 questions. 1. Does your patient have a fever? 2. Does your patient have a cough or difficulty breathing? 3. Does your patient have an increased respiratory rate? 4. Does your patient have any emergency signs, such as obstructed or absent breathing, severe respiratory distress, central cyanosis, shock, coma, convulsions, or uncontrolled vomiting? 5. Is your patient being admitted as an inpatient? Fever. Any known fever over the last 14 days is an indication to measure oxygen saturation. Cough or difficulty breathing. Any cough, difficulty with breathing, or shortness of breath over the last 14 days is an indication to measure oxygen saturation. Difficulty breathing can be any abnormal breathing pattern, including but not limited to breathing too fast, too slow, too deep, noisy breathing, labored breathing, or any pain or discomfort associated with breathing. Increased respiratory rate. An increased respiratory rate is an indication to measure oxygen saturation. This is a little more complicated than the other reasons to measure saturation, as normal respiratory rate varies with age. Let's spend a little time here reminding ourselves of abnormally high respiratory rates in different age groups. In adults and children 16 years of age and older, a respiratory rate of 22 breaths per minute or more is abnormal. In children 5 to 15 years of age, a respiratory rate of 30 breaths per minute or more is abnormal. In younger children from 1 to 5 years of age, a respiratory rate of 40 breaths per minute or more is abnormal. In infants 2 to 11 months of age, a respiratory rate of 50 breaths per minute or more is abnormal. In neonates and very young infants up to 2 months of age, A respiratory rate of 60 breaths per minute or more is abnormal. Any patient who has an increased respiratory rate should have their oxygen saturation measured with a pulse oximeter. Emergency signs. Emergency signs are an immediate indication for admission and resuscitation, including administering oxygen therapy. Resuscitate, administer oxygen, and measure the patient's oxygen saturation if any of the following signs are present. Severe respiratory distress. Signs of severe respiratory distress can include obstructed or absent breathing, head nodding in younger children, nasal flaring, grunting, usually in younger children, tracheal tugging, intercostal retraction or inward pulling of the skin between the ribs during inspiration, and deep lower chest wall indrawing or inward pulling of the skin below the ribs during inspiration. Other emergency signs include poor perfusion or weak pulse, which is a sign of shock, coma, convulsions or seizures, or vomiting all food and drink and medicines. If your patient is being admitted to the hospital with suspected or confirmed COVID-19, or for any other respiratory illness, use a pulse oximeter to check oxygen saturation, along with vital signs. For patients who are under simple observation and do not have low oxygen levels, these should be checked at least every 6 to 12 hours, depending on illness severity. How to measure oxygen saturation. When using a pulse oximeter to measure oxygen saturation, remember to use the correct probe for your patient. Young children in particular need appropriately sized probes. It may be difficult to get a reading in critically sick patients. We recommend 2 strategies to make it easier to measure the oxygen saturation in younger children below 2 years of age. First, using the big toe, as this allows the child to sit comfortably in the caregiver's lap and be comforted. Second, you may allow a breastfeeding child to feed during the measurement to improve cooperation. You may have to wait 30 to 45 seconds for the pulse oximeter to display the pulse rate and oxygen saturation readings. If your patient is very unwell and you cannot get a reading, administer oxygen and call for help immediately. How to use the oxygen saturation to decide next steps. You have now used a pulse oximeter to measure the oxygen saturation of your patient. Depending on the result, you will decide to administer oxygen or plan how to monitor your patient without oxygen therapy. If the patient's oxygen saturation is 94% or higher, and they do not have any emergency signs, you do not need to administer oxygen at this point. In this case, you should follow local protocols for COVID-19 testing and isolation. Remember, all inpatients should have their oxygen saturation measured with their vital signs every 6 to 12 hours. If the oxygen saturation reading is less than 94%, or if there are emergency signs, administer oxygen via nasal prongs or standard oxygen face mask, and check the saturation every 2 to 5 minutes. The next oxygen therapy decision is made depending on the outcome of 15 minutes of oxygen therapy. After 15 minutes of oxygen therapy, check the oxygen saturation again with your pulse oximeter, and check whether the reading is 90% or above or less than 90%. If the oxygen saturation is 90% or above, continue standard oxygen therapy as you are doing and monitor the patient. If oxygen saturations rise to 96% or higher, reduce the oxygen flow rate. Oxygen saturation and vital signs should be measured at least every 4 to 6 hours while oxygen therapy is ongoing. If the oxygen saturation is less than 90%, oxygen support should be maximized. Oxygen flow should be increased where possible. Other measures include using a face mask with an oxygen reservoir for adults and a head hood for infants. Once again, oxygen saturation should be checked every 2 to 5 minutes. Check oxygen saturation using a pulse oximeter after 15 minutes of maximal low-flow oxygen therapy. If the oxygen saturation is 90% or above, continue maximal oxygen therapy and monitor the patient. Oxygen saturation and vital signs should be measured at least every 4 to 6 hours while oxygen therapy is ongoing. Oxygen saturation should be maintained between 90 and 96%. If the oxygen saturation is less than 90% on maximal oxygen therapy, refer for ICU admission where available, and escalate respiratory support where possible. Oxygen saturation should ideally be monitored continuously. Oxygen saturation measurement is the best tool you have to decide when to use and maximize precious oxygen resources during the COVID-19 pandemic. We thank you for all that you are doing for your patients during these difficult times.
Wow, that was a wonderful video. It has actually somehow given us a summary of today's topic.
El video demuestra el uso de un oxímetro de pulso en el contexto de la pandemia de COVID.
Okay. I'm not sure, maybe it's time now to have a short discussion. Time for us to give our idea and the interpretation of the patient's arrival and then how it was taken care of. And at some point, I think Christina will help us to give a better understanding of the use of pulse oximeter and then how people who do not have it, maybe you have an idea on how they can acquire one or two so that it can help them to do better diagnosis of hypoxemia in a different location of the institution.
Yeah, so if you don't have access to pulse oximetry in your location where you practice, one of the missions of the main mission of Lifebox is actually to provide these pulse oximetries worldwide to improve patient safety in all anesthetic delivery locations. So we really hope that you will contact us, especially if you're on this today or if you have colleagues that don't have access to regular use of pulse oximetry. Please contact us. I will put information in the chat box, and we will do our best to try to administer and assess your needs and get more pulse oximetry access, as well as potential additional education to providers.
Okay, thank you. I guess the information is seen. I'm not sure among the panelists if there's someone who has a few comments to make over the video or the first part of the discussion. Maybe I should mention one, Julia. Any comments?
Not so far. I guess I'm curious if people are having trouble using pulse oximetry in their settings. What are the problems they may be having that we could discuss now? The video makes it look very easy. You just put it on and then you get a little thing. But if people are having trouble, this is a good time to talk about it.
Okay. So maybe in the live box, our audience can share the difficulties that they are facing with their pulse oximeter. It doesn't matter the make, not only for Lifebox, we can have a pulse oximeter of different make. The principle is still the same. So you can still share the difficulties that you are facing, and then you will get assistance from any of our panelists during this discussion.
We have a question from the chat box here, Dr. Papicho. How accurate are non-medical grade pulse oximeters?
Please come up again with the question.
The question was, how accurate are non-medical grade pulse oximeters? So I think there's some that you can buy online or you can get through various companies that are not, they don't have certifications. They may not have CE certification. And so how trustworthy do you think they are, and is there a way to test them?
I think for medical equipment, it's always recommended that you get them from a trusted source. You get them from a source that has been recognized or certified. with the certificate. So if you are buying online, it's better to go for a make that it's well known, or from a company that is selling online, but a company that has a CE certification, so that you can avoid getting a machine or a device that might not give you accurate readings. And there's always calibration that is done on these devices. So I will not be able to certify that a machine bought online, it's actually giving you accurate. Maybe unless if you keep on comparing it with a machine or a device that we are using in your institution, and that has been certified and then calibrated before, and then you can see if it's giving you accurate result or not.
Yeah, I would also recommend, that's a good idea to compare it to a certified machine. Also, if you need to buy cheaper machines, if you can at least buy one that has a waveform and not just the number, that helps a lot to know whether your pulse oximeter is accurate, if you can see a good waveform. And finally, test it out on healthy people and see if it's reading 98, 99%, and then test it out on people that you think probably are hypoxic, so you can get a sense of whether it's really working or not.
May I add something? One of the, Alana pointed out in the chat box, one of the more common questions we get from participants is the reliability of clinical signs versus the reliability of pulse oximetry. And I think just discussing the quality of pulse oximetry is one consideration. But also, if you have a patient that has clinical signs and symptoms of respiratory distress and possible hypoxemia, or you have a pulse oximeter that's reading low, but you're unsure of the quality, that the best thing to do clinically is to provide oxygen to that patient until you can verify whether or not that patient is hypoxemic. So I would always err on the side of taking care of the patient and then trusting your data thereafter if you have any question about the patient status. Additionally, with COVID-19 considerations, there are patients that will appear relatively stable clinically, but do have moderate to severe hypoxemia. So those patients, even though they may not have very obvious shortness of breath, et cetera, they are hypoxic. So again, I would err on the side of providing oxygen if there's a question of the patient's clinical status or if the pulse oximeter's reliability is in question.
Okay, thank you for your comment and participation. Any more comments, Julia?
Julia, you're muted still.
Sorry, we have another great question from the chat, Papicho, if we have time for one more.
Yeah, please.
The question is there a relationship between cardiac output and pulse oximetry? I'd like to take that one.
Yeah.
Dr. Palan, maybe?
Yeah, this, you are calling me to step in?
Diego.
So,
Yes. Not sure if
I think I can just put up somewhere. I can put up some words on this question. Somehow there should be a relationship between the cardiac output and the pulse oximetry, because one of the factors that can interact with the readings of the oximetry is low perfusion rate and kind of things. So if the patient is poorly perfused or if is hypovolemic, we might have difficulties in getting a good readings. So it can somehow affect the beta readings, and then you might not get the actual readings that the pulse oximetry should give you. Yeah. I don't know if there's any more comment from the panelists.
I just, as far as cardiac output, but also like in the setting of, not so much in COVID, we aren't seeing sepsis as much, but in the setting of sepsis where someone has very poor oxygen perfusion, they will have low pulse oximetry. And even if, one of the biggest things is like Julia had mentioned earlier, is you want to have pulse oximetry that has the waveform. This will let you know, if your reading is reliable or if it's due to artifact or other reasonings.
Yeah, I was just going to add that it's called a pulse oximeter, which means you have to have a pulse, a detectable pulse, for the data to be interpreted. So things that can affect the device's ability to detect the pulse, whether it's vasoconstriction, hypothermia, poor perfusion, et cetera, any of those situations can decrease the pulse to the finger or an extremity, and therefore the pulse oximeter's ability to interpret the data. So you must have a pulse. So cardiac output was mentioned, vasoconstriction, et cetera. So all of those things are imperative.
Thank you very much for your contributions for this nice discussion that is taking place. At this point of time, I would invite my friend Pauline to come in and take up.
Thank you very much, Papicho. That was a very interesting discussion, and the whole panelists. Now, another question which is just coming after. You attend a patient who was hypoxic and the pulse oximeter was showing very low results. Your first reflex, you put on oxygen. The question is, how long after starting oxygen should your pulse oximeter, your SpO2 increase? How long do you wait? Sometimes you are stressed. The SpO2 is dropping, so you just understand that the patient may die with hypoxia. You just put oxygen. How long do you wait? How long after starting the oxygen should the SpO2 increase? So we have 1 minute to suggest some answers before continuing the discussion. Please feel free to drop some answers for discussion.
So in the chat box, many people are saying 10 to 15 minutes. A few people have said 3 to 5 minutes. I know one of the things that we discuss is the latency, or how long it can take for the time you place the pulse oximeter on your patient to get an accurate reading of that patient. So that latency is usually in a medical grade pulse oximeter about 30 to 45 seconds. And so from the time that you place the pulse oximeter on, your reading is not going to be accurate until that time. So if you do any sort of intervention, oxygen included, you want to make sure that you're not looking for an immediate change. It should change within 30 to 45 seconds. And so that's just to get an accurate reading from the pulse oximeter. As far as once the oxygenation has improved, usually you want to reassess within 3 to 5 minutes. I agree.
Hi, Pauline, if you're trying to say something, then just wanted to let you know that you're muted.
Oh, sorry. I I don't know how it comes. So I'm telling that thank you very much for the answer from Christina. So I was trying to tell my colleague that sometimes we are too pushy and we want it to give you the result right away, 10 seconds, and you start changing the toe, you change another one, so you are delaying it. So give it 30 seconds. And then don't go beyond 1 minute, because then maybe you are not on the right position, maybe your pulse oximeter is not working, maybe the toes or the finger are not well warmed. So you need to rule out all those factors which can compromise your pulse oximeter function well. So you have around 1 to 1.5 minutes, 1 minute enough to decide if really it is functioning or not, so that you can act. So don't be too fast before 30 seconds. Don't wait longer, more than 2 minutes. So if you say 5 minutes, 10 minutes, then it will be late by the time you see the results. So not very long than 2 minutes. So as we have, if we understand the correlation between the pulse oximeter and the cardiac output and the rate of hemoglobin, all those factors influencing the pulse oximeter. So we understand that if in the 1 minute to come, you don't have a good result and you are sure you've put your pulse oximeter on, you're sure it's working, you're sure the toe is well perfused, then either you have a problem or you need to increase the flow or you need to take action, the next action. So the other question is, if you see the picture in front of you, the question is, rank those oxygen delivery devices in order from least FiO2 delivered to the highest FiO2 delivered. Which one delivered the least? Which one delivers the highest? So there is some answers coming in while we are waiting for. We are also expecting the one manipulating the screen to give us the article discussing on the pulse oximeter resources. So someone says 1, 2, 3, 4. I think maybe I can give time to Julia to take us through the right answer on this question. Julia, you are muted. If you can, okay.
Okay, sure. Yeah. So so from left to right, what we have is a simple face mask, and then next is a Venturi face mask. Oh, I lost the picture. There it is. Then there's a Venturi face mask with different connections that, when you change them, can provide a different level of FiO2. So there's a wide range. And then next, as we go to the right, is a simple nasal cannula. And then after that is what's called a non-rebreather face mask. So the nasal cannula provides the lowest amount of oxygen. Depending on how much you're flowing, it will be between 21% on room air or up to 40%. No matter how high you turn up the flows on a nasal cannula, you really can't get above 40%. Next then would be the simple face mask, which can get you all the way up to somewhere around 60% at the most. The next highest would be the Venturi, which sometimes can get you up to about 70%. And then finally, the non-rebreather mask all the way to the right can get you to 100%. So that's the most amount of oxygen you can deliver. However, it does come with a little bit more danger. You have to be careful when you're using a non-rebreather, because if the oxygen supply gets disconnected, they will rebreathe their own carbon dioxide. So just make sure that oxygen is always flowing to the non-rebreather mask.
So you take 3, then 1, 2, then 4. So remember this one, some people will keep increasing the flow, try to have an highest FiO2. The higher the flow, it irritates the nasal. So you, at some point, up to 3 to 4 liters, it means you need to pass to the mask. So as the more the higher you are going with the flow, think about the mask. So then after, if the mask also needs more and higher flow, think about the Venturi. Venturi is not very common in our settings. I don't know some other settings, like in Rwanda, we don't have Venturi, so we will pass, when the facial mask is not working properly, we'll pass to the non-rebreather, changing the flow from 10 up to 15. So at this point,
I would like to make another comment in terms of care of these devices. I believe in most of our places, we don't use them as single-use device. We reuse them. So we need to take good care in terms of cleaning to avoid cross infection from one patient to another one. There's a recommendation from WHO about the solution to use and the dilution of the same solution of the sodium hypochlorite so that they're nicely clean. First you rinse them with running water and then you soak them in the jig solution, sodium hypochlorite, for 5 to 10 minutes, and then you rinse them again, and then you hang them to dry. We also have to remember doing this, because if we don't do that, the next patient who come can get a cross infection from the previous user. So I thought it was also another point that we needed to share during this discussion.
thank you very much, Papicho. Maybe this one will not concern Anna and Julia, because they don't know those settings where we reuse those masks, and but for us, we visit some hospitals where you found our colleagues are reusing the facial mask, especially in like at OB. They know we rarely put oxygen, but they have one mask. When the mother needs oxygen, they just put the mask, remove, put another one. So you need to learn how to clean those devices, as Papicho is saying. So let me give the panel back to Papicho to continue the next step.
May I call on our co-panelist, Dr. Farai, to comment on the use of Venturi, because in Zimbabwe and Botswana, I believe they do have Venturi masks and use them fairly often. So I don't know if Farai can unmute himself and give us a comment or two about Venturi valves. He's on the line. Farai, are you available? He stepped away. Okay, it's fine. We can continue, sorry.
So Papicho, can you go?
Okay, thank you.
Yeah, okay, I'm ready now. Yeah, sorry, I needed the host to unmute me to carry on. We in Zim, Venturi is very widely used. It is almost, at least for anesthesia, in anesthesia practice, it's almost a standard way in which we give oxygen. Although in Botswana, right next door where I am, it's virtually unknown. I think the big problem really with the Venturi is that a lot of people use them but do not understand the difference between the ordinary face mask and the Venturi mask. And the color coding is also often confusing because different companies present different colors. So it often requires quite a lot of teaching for people to get used to the fact that when you are using a particular, that when you are using a Venturi mask, you have to set a specific flow or flow range with a particular Venturi device to get the oxygen saturation that you want. Yeah, like I said, it is quite widely used. And I think also probably in this COVID situation, it is not quite a stopgap, but it is a bridge between the ordinary face mask and being able to deliver a higher oxygen flow, higher than what you can get with an ordinary mask. The rebreathing mask is much more difficult, for us to have. Yeah.
I just want to mention I've included a few links in the chat box for people. One of the things that we were talking about was how to escalate care, and the Lifebox has developed a tool, and this was also part of our learning objectives. I know we're going to talk about it here shortly, but there's a link there that you can access that tool, as well as a video from YouTube showing how to care for your pulse oximetry. This shows a Lifebox, but it can apply to any brand, and how to clean in between patients to avoid cross-contamination.
Papicho, are you ready with the next step?
It looks like he froze, I think, so.
So let us continue. So the next step, as we are also preparing the flow for Papicho, we continue with the case. You continue to perform a history and physical exam and discover the following. So in the past medical history, we found that he had polio and diabetes mellitus type 2 and HIV. And in the surgical history, he had years ago, more than 30 years ago, he had that he underwent hernia repair. So he's an HIV on treatment, and the long-acting insulin and preprandial sliding scale insulin. So in the family story, the mother deceased, and she had an history of hypertension, diabetes, and also the father deceased with emphysema. One younger sister, he has one younger sister, and 2 children healthy. The social history works in construction, and he takes 2 alcohol drinks 3 times a week, and doesn't smoke, doesn't use illicit drugs. So he has that left facial drop from childhood polio, otherwise negative, other than, so your nursing going down, your nursing, so what did you plug oxygen, what did you plug the oxygen into? Where does the oxygen come from? That's the question from your nurse as you are giving oxygen. What are the different types of oxygen supply which does your facility use? So maybe you can give us some suggestions, some ideas in your settings. What are the different types of oxygen supply and which does your facility use? Drop for us few answers before we continue. So I can see as answers are coming, we are having some will say the plant, oxygen plant, some are saying cylinders, and we have others with concentrators. All are good. I would also like if someone can tell us if they have liquid oxygen. Do we have some who are using liquid oxygen in the African setting or low-income countries settings? Dr. Fezai, can you tell us the experience in Botswana, where you are now, comparing Botswana and Zim?
Oh, okay. So where I am right now in the city where I am, there's two big hospitals. One uses the liquid oxygen tank, and the other one uses an oxygen concentrator plant. But also the maintenance of that has been a huge problem. So they have set up a very large manifold with about 80 cylinders on each side, which supplies the hospital and the ICU. In Zim, the main hospitals use oxygen tanks, the liquid oxygen, but most of the hospitals rely on oxygen cylinders. Some have manifolds, some don't have manifolds, but they are completely dependent on oxygen cylinders. Yeah.
I think we share with all of us, many of the low-income countries share the same experience on using
and share mine also.
concentrate. Oh, Papicho, yes, can you comment a little bit about Zambia and other places you've been?
Yes, this place in Zambia, most of the institution uses cylinders, and it's only at the main hospital, the teaching hospital in Lusaka, where there is an oxygen plant. And remember, they have a facility to refill cylinders. So all the hospitals in the surroundings of the capital, they have that benefit of getting free oxygen, cylinders being refilled. Whereby other institutions that are far from there, they use cylinders, but they buy now from private companies who do have oxygen plants, and then they refill cylinders at a cost. Deep inside in the rural areas, you might find cylinders that have been empty for years because it's difficult to access a place where they can refill them. So there, what is being used now is the oxygen, the concentrators. And these concentrators are giving also issues because when they stay long, they need maintenance, they need to be serviced. And down there in the bush, there's no one who's capable of servicing them, or at times, electricity supply is also causing a problem. These are the difficulties that we face sometimes in different places when it comes to oxygen supply. At our institution, we had a manifold. Unfortunately, after times, the pipe started leaking, and the leaks were just too much that it was not being useful to get oxygen from the manifold. So now we started moving cylinders around. And remember, moving a cylinder, it's got its dangers, and then risk of accidents, dropping a cylinder, it's heavy. You need a trolley, you need people to move it around. So those are the difficulties and challenges that we have sometimes in different institutions, based on the location and based on the finances that you get for you to get some oxygen supply.
May I just point out, Dr. Papicho and Dr. Paulin, also that Assist International does a lot of work in oxygen supply and procurement. And in fact, there's an entire module on the Learning Resource Center that discusses oxygen in all its forms, the oxygen plants, concentrators, and cylinders. And I would just encourage participants to review that if they are involved in oxygen supply for their facility, because there's a lot of safety considerations, and there's also some useful planning tools. Depending upon the size of your facility and the types of patients you care for, will determine the type of oxygen supply that is most appropriate for your facility. So there's a lot of resources out there on the Learning Resource Center. If you're interested in learning more about that, you can either leave a comment on the community page on the LRC, or you can use the WhatsApp link and we can direct you to those resources.
Thank you very much, Hannah. So as we are learning this paragraph, for some who are not very like critical care or anesthetists, we are talking about the fraction of oxygen. So it's all about FiO2, fraction of inspired oxygen into the mixture you are inhalating. So in the air, we have 21%, which means 0.21 fraction of oxygen. So to increase that FiO2, you increase you just supply oxygen. So if you supply less, a low flow, like for nasal cannula, you increase a flow, which will, at the time of inspiration, it will mix with another, the air you are taking from the normal air. So it will increase a little bit the FiO2, the fraction. So if you increase again the flow to 5, that nasal is not appropriate. You go to the facial mask, which allow you to increase a higher flow, which will keep mixing with the air around you, increase, but not make it 100%. Then if you want higher flow, you go to the venturi, and then you go to another non-rebreather. So it's about the flow. And that flow also will depend on the supplier. If it's a concentrator, some concentrators are limited to 5 liters per minute. So you can't go beyond, because the concentrator, when you purchase it, it was for 5 liters. Some will go to 10 liters. So then at one point, you can't make it, you can't go higher. You go to the cylinders. The cylinder again, so for the concentrator, many of the maintenance which are easy and everyone can do it, behind the concentrator, there is a filter. It is something you can just wash with water and clean it and put on the sun. And then when it's dry, put it back again. Because if you don't clean it, it ends up closing or obstructing the sucking the air to be what can I say? To be concentrated into oxygen. So for the cylinder, as Dr. As Papito is saying, some people don't check on the manometer how much oxygen is left. So you keep, some of my potters will take the cylinder and try to try if it's heavy. And they think if it's heavy, mean there is oxygen inside. No, you need to have a manometer to check your cylinder. If it is, how is the pressure in your cylinder? That's how you check. You don't check it by elevating it and feel like the way will increase. So that those are the small things you need to install in your service, so people will know how to check if the device you are having is functioning or not. It's very devastating when you need oxygen and you found the cylinder is empty. So now the next question will be, some people will keep patient on oxygen forever. So when do we decide to de-escalate oxygen? When do we, if you can drop answers into the suggestion box, when do we decide to start going down on oxygen? I've had some discussion with my students where I tell them, you are wasting money. It's just like throwing away $100 per minute because of the oxygen you keep open. So when do you decide, and how do you escalate? How do you decide to de-escalate or not? Julia, did you manage to have some answers? Do you want to comment a little bit on different questions and suggestions?
The folks in the chat, there's sort of a range between, some people say 94%, some say 95 or 96. I would say that you continue to attempt to wean the oxygen while keeping the oxygen saturation greater than, some people would even say 92%, but somewhere between 92 and 94%, I think you should keep trying to wean and see if the oxygen saturation goes less than 92 or 93. It doesn't have to be, as long as you're in a safe situation, it doesn't have to be 95, 96, 97. You can keep trying to wean. And then if the saturation dips too low for comfort, you can always go back up.
Thank you very much, Julia. Don't know if another panelist is willing to add on before.
Paulin?
Yes, please. Go ahead.
When discussing the source, the supply, we only talk more about the low and middle income countries. Maybe for the interest of all the audience, we can give a chance to the panelists that are practicing in the high resources centers. Maybe they can also give us an idea of the little challenges if they have the oxygen supply, or I thought there's no challenges using the plant or liquid oxygen. They face challenges whereby sometimes it's not working and then they have to run 2 cylinders. I don't know. Is Alex there? Alex Milan?
Sorry, Papicho, were you saying, does that happen in the low resource places or the high resource? I didn't quite catch the question.
The high resources. I and Pauline will discuss mostly what's happened in the low resources. Maybe for the interest of all of us, you can give us an idea of what goes through in the high resources. Does it happen also sometimes whereby the plant or the liquid oxygen gives you challenges and then you go back to cylinders?
Yeah, the thing that comes to mind that happens occasionally for me in our practice is the power does go out. Occasionally there'll be a fire or some sort of electricity failure, and it causes a lot of confusion and chaos, especially in the operating rooms for people who are under anesthesia. And people are not as familiar with switching to other modes of giving oxygen, you know, in our setting, because they get used to having the constant supply. So switching to cylinders and switching to a non-rebreather bag and just using room air is something that's it can be uncomfortable for people. So it's something that we train in regularly. And there's simulations of what will happen if you lose your oxygen supply or if you lose power, so that people stay comfortable with it.
Okay, that's interesting.
Actually, if I can also add to that. So we had a situation a few months ago where one of the hospitals that relies on an oxygen tank, there was some problem with the tank, and the company that supplies the oxygen actually offered to send one of the actual delivery truck. They could supply the hospital oxygen from the delivery truck directly onto the hospital system. Now, I'd not heard of that happening anywhere, and I don't know how really feasible it is. It didn't actually happen in the end for other reasons, but I thought that was an interesting solution to that problem. Yeah, I don't know if anyone knows anything about that.
Not very familiar with this problem. Anyone would like to step in? Meanwhile, we are requesting Christina to prepare the review of how to use the tool on decision making of pulse oximeter in COVID-19.
Are we
Can
able
you-
to share a screen to show the tool?
Am I sharing the screen for decision making? So as we are waiting for, okay, the screen is there.
Yeah,
So
I started to share mine, so I think that's, can everyone see that?
Yes, thank you.
Yes, it looks good.
Okay, great. So this tool is available readily, and this is something that was developed by a collaboration of physicians early on in April in the pandemic. And this is to help guide you in the real-time setting for how to approach patients. So, you know, initially starting with symptoms, does patient have any of the following? So of course, starting with our fever, cough, shortness of breath, and then respiratory rate. And this is designated here and delineated here by age group, because of course respiratory rate's going to be highly variable for a neonate versus an older adult. And then emergency signs such as obstructed or absent breathing, severe respiratory distress, central cyanosis, shock, coma, and convulsions. So these are all pretty severe situations. I'm hoping most of these patients are either already in an acute facility or can be transferred to one for a higher level of care. So if this is the situation, if you have access to pulse oximetry at this time, that's when you would want to assess with a pulse oximeter your patient's oxygen saturation. So if they do meet this criteria, you assess their oxygen. At this time, if their pulse oximeter is reading 94% or higher and don't have any of these emergency signs, you would move over here using the WHO and local protocols for testing and isolation. And this is a situation where, you know, you want to, especially in the acute phase, but also as we have waves of increasing infections, these are the patients that you want to manage, you know, at home and as an outpatient or in your home clinic setting. So follow that for testing and isolation depending on your local protocol for that. If they start to develop any emergency signs, of course, then you would want to reassess your pulse oximetry, and you escalate care based on your pulse oximetry. Now back here, if your oxygen at that time when you first place your pulse oximeter, if it's less than 94%, or they have some of these emergency signs right here of the obstructed breathing, severe respiratory distress, shock, coma, convulsions, you would want to escalate your care at that time and go through the escalation of oxygen like we had mentioned earlier. So initially, starting with that lowest fractional oxygen, the FiO2, fractional oxygen starting with nasal prongs, because that's going to be able to provide the lowest level of oxygen, supplemental oxygen with decreasing risk for aerosolization. So you would want to initiate this oxygen therapy, and it states here to recheck after 15 minutes, which we mentioned earlier. When should we recheck pulse oximetry? Now, it depends on your setting. If you have the ability to have continuous pulse oximetry on that patient, you can do so. And with the latency of the pulse oximetry being about 30 to 45 seconds, you should see some improvement of symptoms and oxygen saturation after a minute or so. However, if your access to pulse oximetry is more limited, at a minimum, you want to reassess that patient with pulse oximetry in 15 minutes. So if there are additional emergency signs, you want to reassess the patient with pulse oximetry at more frequent intervals. 2 to 5 minutes and titrating your oxygen to keep your saturation higher than 94%. So to continue the algorithm, if you don't have any of those emergency signs mentioned up here, then you would want to continue inpatient management with WHO and local protocols, assessing every 4 to 6 hours at a minimum for your pulse oximetry while they're on oxygen therapy. And then your goal, like Dr. Weinkoff and Dr. Crawford had mentioned earlier, is going to be to keep your oxygen saturation between 90 and 96%, reducing oxygen flow rates as possible. So, you know, after the patient, as long as the patient is stable, you can gradually try to decrease your oxygen flow rates to continue to maintain your oxygen saturation at these levels. Pregnant patients, the recommendation is slightly higher, 92 to 96%. Now back here, if the patient has saturation less than 90% or less than or equal to 90% or any of those emergency signs, you want to escalate your therapy at that time. So this is where we would move to the face mask with reservoir, which is also known as a non-rebreather, that one with the bag at the bottom, or possibly a head hood that may be available in your institution for infants. Again, if you have the ability to continuously monitor your pulse oximetry, you should do so. But if not, at a minimum, you want to reassess after 15 minutes. If they do continue to have the emergency signs, the obstructed breathing or these other things, you want to reassess your oxygen, your saturation every 2 to 5 minutes. And again, keeping your saturations higher than or equal to 94%. Ultimately, if this therapy is continued and your oxygen saturation maintains low, you need to escalate therapy even higher. Sorry, my phone is ringing. Maximize your oxygen therapy and support, and that may be, you know, intubation, that may be high flow nasal cannula oxygen if you have these resources available. Back here, you know, it's basically that cycle of assessment, reassessment, and you may be able to escalate or de-escalate your care based on these signs. Now, the other thing is that this tool provides some definitions, and so this is where it comes back to the oxygen saturation versus clinical signs and symptoms. So history, clinical signs and symptoms are important, and maybe not more important, but as important as your pulse oximetry readings and assessment of your patient clinically. So this tool is available, and I will place the link again in the chat box. I'm going to stop sharing unless there's specific questions about the tool right now.
That was good. Is there any comment about the decision making on this tool? Please feel free to share it on in the chat or on the WhatsApp. So we've discussed this decision making. We've discussed different tools for oxygen supply in the facilities. So now we'll share the screen again on the case. If you have a question about when you are using oxygen, you are supplying oxygen to your patient, and you are asked a question, what's wrong with your patient? So let us. So as you can see, suddenly the pulse oximeter starts to alarm. Your student asks, what is wrong with the patient? So,
can you interpret this SpO2 tracing? What is the heart rate? What is the SpO2?
So the SpO2 reads 83%, but if you look at the waveform, it's uneven and inconsistent. So if the waveform is not good, then the values displayed by the pulse oximeter are inaccurate and unreliable. You can try repositioning the probe, covering the probe from ambient light, or moving to an extremity with better perfusion. So this goes back to Dr. Weinkauf's comments about making sure that you have a pulse oximeter which has a waveform. So again, the heart rate is 55, but because the waveform is not consistent.
Can you interpret this SpO2 tracing?
So you can see the waveform does not correspond with the heart rate or the heartbeats or the cardiac output, so that the data that the pulse oximeter gives you is unreliable.
So now you see how you reply to your student. She was, the student was alert. She could listen to that wave, which the sound was not good. It was a bradycardia and the number was not good. So the good way you can answer your student is because this curve is not good. And remember, sometimes ago, Julia told us, when you are buying through internet or whatever, make sure you buy something with a curve, because this wave will help you interpreting some or troubleshooting some wrong results. So as we are moving again, if you can give a floor to one of the panelists to comment on this answer. It happened that we have such answers, such question, and how will you take it with your students? How do you explain to them? How do you make them to be alert in such discussion? Azai, do you have something to add on?
Pauline and Papicho, if you don't mind, I'll just mention that the time is now an hour and a half for this session. So we want to be respectful of people's time. So if you are unable to stay on the call, we understand, but our leads of the discussion are willing to continue going over resources. So you're also welcome to stay. So we'll continue the webinar, recognizing that some people may need to leave at this time.
Thank you, Hannah, for the updates. We'll try and go a bit more faster, but trying to share the most important things, not skipping any. Yeah.
So as we are continuing, so soon we'll also close as we are moving. We are about to finish. This is a short session, then Papicho will take over to summarize before Anna closes the session. So we are, another question to the audience, see if we are on the same page. What factors can interfere with a pulse oximeter reading? If you can drop some answers into the chat. What are the factors which can interfere with a pulse oximeter reading?
What I was going to say is that tomorrow can we find IT? An IT lady? She's probably not going to be here. Probably don't know. Yeah, just to help with sorting that out. Yeah. Because I'm going to be here.
I can see many people are putting the raised hand, wearing a glove with patients. So,
well, right now it's connected on the thingy. But if I go...
Can you are you willing to step in and discuss? We are discussing about factors who can interfere with the reading on the pulse oximeter. So some people are putting here raising the hand, others are talking about the gloves. So if can hear from Farai, can you take us through some factors which can interfere? So we know when you raise the hands, yes, but the problem will be, maybe it will be hypoperfusion. So when you are wearing, if your patient is wearing a glove, it is the connection between your nail and that light from your pulse oximeter. So beyond that, we have some ladies or men can put on the nail some products that also can interfere. So some patients, some people talk about the coldness. If you are cold, you have cold extremities, because as Anna said, it is a pulse oximeter. So any factor which will vasoconstrict your periphery will impair your pulse. So because you don't have a good pulse, so the oximeter, because the pulse is not good, the oximeter will be difficult to read and can go wrong. So Papicho, any other factors you want to discuss?
Yes, sometimes
I have a question, one question to everyone. I have asked any question? Have I hearing? Hearing me?
Yes, Professor, go ahead.
Yeah. Now, I have a question. What are your experience about the PA2 and FiO2 and SpO2 in case of COVID patient and a comparison to the normal patient? There is any difference between these three findings in relationship with the norm compared to other normal patient except in COVID patient? And about oxygenation?
When we see hypoxemia in our COVID positive patients, we see it both using the pulse oximeter, so we see it on SpO2. We also see it on arterial blood gas analysis, the PaO2. So those numbers are corresponding in COVID positive patients. So the hypoxemia is real and verifiable clinically using pulse oximetry as well as arterial blood gas analysis.
Can I add one more thing? A lot of our guidelines for ARDS management, which is what these COVID patients have, adult respiratory distress syndrome or acute respiratory distress syndrome, a lot of the guidelines refer to P to F ratios, the PaO2 to the FiO2, but a lot of low resource settings don't have arterial blood gas monitoring. And there has been studies that show that the SpO2, meaning the pulse oximeter to FiO2 ratio, correlates very well to P to F ratios. This is a little bit advanced. It's more for the ICU setting. If some of you have ICUs in your hospitals, you should know that the SpO2 to FiO2 ratio correlates well to P to F ratios. So you can use that in guiding therapy of your ARDS COVID patients without arterial blood gas monitoring.
Well, thank you very much, Julia. So for some of you, if you want to take more of, to understand or to read more of what Julia is saying, if you Google, simple Google on Kigali modification of RDS, you will find an article published by Twagiru Mugabe Theogene discussing about some, you can use some factors. If you don't have a blood gas machine, you can use the SpO2 over FiO2 to tackle some cases of early hypoxia, even without a blood gas machine. So it's feasible and it's very helpful. So as Anna, do you want to say something?
I'm going to point out to Pauline, if I may, on the Learning Resource Center, there's a course you know, we're in the oxygen series course, but there's another course called the Fundamentals of Critical Care, which discusses ARDS. It also discusses the Kigali modification for the definition of ARDS and using pulse oximetry instead of arterial blood gas analysis. So that's on the part of the course as well.
Okay. So next is Papicho. So I think we've discussed most of the oxygen supply. We've discussed the functioning of the pulse oximeter. We've discussed how to troubleshoot or to tackle a wrong reading. So now I think we need to do a review, and Papicho will take us through this.
Thank you very much, Pauline. Thank you very much to all the panelists and the audience. This has been a very great interactive discussion so far. We'd just like to highlight some of the points that we mentioned during our discussion, during our 2 hours discussion almost. The first is like oxygen supply devices. We read from different parts of the globe what type of supply we use and what are the challenges that can come along. I think at this point, it's more important that we happen to choose or to direct our management to acquire the supply that will give us less headache, less challenges, looking at the environment where we are practicing from. When it comes to the non-invasive oxygen delivery device, we might not have all of them that were described during this discussion, but if we can manage to get a supply of different type, it will also be fine, so that time to time we can move from one device to the next one if patient is not doing fine. As we just learned today that the difference in terms of FiO2 differs from one device to another one. The oxygen therapy escalation and fraction of inspired oxygen, this is what he says. It also depends on how much flow and the device that you are using, and how good your patient is doing, and then what's wrong with it. So it's all about a clinical examination and clinical vigilance as we are treating our patient, not only relying on the monitor to get information about the patient, but we are clinicians, and then we should spend more time to read what the patient is presenting. Our last point, I think, is to remind all our audience that on the LRC, on the learning resources, everything is available. So we should focus, we should spend some time to go back on the LRC and get enough resources that is there, so that we can get to know, can spend time so that we get to know how to navigate on the LRC, how to get the material that is there. There's a lot of information on the LRC, and a lot more is coming. So we can still call others so that they can come up and join us during this discussion for the next one that is coming in the next 4 weeks. As that for now, I think I'll hand over to Anna so that she can close up the discussion of today. Unless if there's any panelists who would like also to make any comments before Anna closed up.
My comment is happy birthday, Papicho. And,
happy birthday, Papicho.
and thank you for a good presentation.
Thank you very much for that. Thank you very much to all. I'm about.
So thank you to Dr. Paulin and Dr. Papicho for an excellent lead on this discussion. As we've mentioned multiple times, on the Learning Resource Center, we have this oxygen course. The link to the LRC is in the chat box. It's also on the WhatsApp thread. But as you can see on the Learning Resource Center, we have several courses. We're talking now about the Oxygen series, but we have a course on COVID-19, the fundamentals of critical care, and some other anesthesia-related resources, as well as a biomedical equipment technician training. So for this discussion, if you go into the Oxygen series, you can see that the second module is the case-based discussion. That's where you will find part 2, which is what we're discussing today, which is diagnosing hypoxemia using pulse oximetry. So here you can access the course and all of the practice improvement objectives. Just a reminder, as Dr. Papicho pointed out, that you can click on this paperclip in the upper right-hand corner and download a checklist. This checklist contains things that you can do to change your practice, to improve your practice, and ideally impact patients' outcomes positively. So throughout the course and throughout this learning module, you can see these action items for practice improvement in orange with the checklist here. And these things are on this downloadable checklist for you to use in your practice. So just want to remind people that that's available to you. If you're a learner, you can do this yourself. If you're a teacher, you can use this to teach your course as well. So again, many thanks to all of our wonderful panelists, this fantastic discussion, and thanks to our partners and collaborators, Project ECHO and Assist International.
Hi, everyone. Thank you. I'm just going to, I have a couple notes as we wrap up the session as well. So just bear with me. I know we are a little bit over time. So on the slide that should show up on your screen now, we do have a couple of reminders. As Anna said, thank you to all of our panelists and all of our funders for making this session possible. In specific, thank you to Project ECHO and the GE Foundation. As a reminder, to obtain a certificate of attendance, you will need to fill out a short survey. We are not providing the link in the chat box, but we will be sending this by email in the next couple of days. Presentation slides and recordings will also be shared in the follow-up email. As a reminder, there isn't an actual PowerPoint deck, but we do have the modules set up on the Learning Resource Center, so instructions to access that will be sent over to you. If you have more questions following the session, we have a very active WhatsApp group, so please feel free to join by either scanning the QR code on the screen. The link will also be emailed in follow-up, and if you have any questions for us at Assist International, our email is on the slide. Thank you so much for joining today, and wishing you all a great rest of the day.